Good evening. My name is Sabrina Wong, and I'm here today as the Associate Director of Research and Teaching Scholarship at the UBC School of Nursing. And I am so pleased to welcome you all to our 56th annual Marion Woodward Lecture. Dr. Elizabeth Saywick, the director of our school, sends her deep regrets for not being here. She's ill, so she didn't want to come and infect you all. So she's doing the good public health nurse thing. That's what she's doing. So we want to begin with an acknowledging that the land on which we gather is the traditional, ancestral, and unceded territory of the Musqueam people. And we are honored to have today Elders Thelma and Arthur Stogan of the Musqueam Nation with us today to share a territorial welcome.
Little short. Good evening, my dear people. My English name is Thelma Stogan. I'm from the Musqueam territory just down the road here. My ancestral name is Leigh, which was handed down to me by my grandma on my mom's side. I want to start off by welcoming you all to the unceded territory of the Musqueam, Tsleil-Waututh, and Squamish Nation. Musqueam. I'm going to say Musqueam. I'm really glad and honored to have you all here. It's always such an honor to know that there's some upcoming doctors, nurses, and everything that we need right out there. I'm going to let my brother squeeze in a few words. Hi, Chika, all my relations.
Good evening, ladies and gentlemen. I'm also here. My name is Arthur Stogan Sr., an elder from the Musqueam First Nations. Tonight, I'm here to welcome each and every one of you into the traditional territory of the Musqueam First Nations. And may you have a wonderful year in UBC. It's one of the biggest places we've ever been to, honestly. But I hope and pray that you all have a good year. And I always say that I ask the mighty Creator to put His hands upon each and every one of you before you leave tonight, and to make it home to your loved ones. It's very important that there's nothing better than getting back to your loved ones. And yeah, I've got 22 grandchildren, so I know how it is to get back home to every one of them. So I appreciate it. I'm an honor to be here, and I want to thank you very much and we welcome you into the Musqueam traditional territory.
That's 22 grandchildren and number 6 great-grandchild coming on the way. Very wealthy.
Thank you, elders. That was really awesome to hear from you. I also want to add that we are so thankful to Mr. and Mrs. P.A. Woodward's Foundation, who has generously supported this Marion Woodward Lecture since 1969. There's a great piece online if you want to know what the philanthropy was of the Woodwards. It's great. So today we are grateful to be able to join here together today. And I also want to acknowledge that today is actually, it's not possible for everyone to be here, for all members of our community. And that this date is Rosh Hashanah, an important Jewish holiday. It is important to acknowledge that geopolitical conflicts and humanitarian crises in Gaza, Ukraine, and other parts of the world are of grave concern for many in our community and around the world. So having said that, we are here today to celebrate nursing as a discipline in the UBC School of Nursing. That was the first program in Canada to offer a nursing degree, and this event provides us the opportunity to dialogue with nursing leaders and scholars. Today, in advance of the keynote lecture, we are pleased to host Dr. Leigh Chapman in dialogue with a panel of UBC nursing faculty. For this year's Symposium dialogue, we focus on nursing leadership in complex health system contexts. It is my pleasure to present our panelists this year. Dr. Leah Lambert and Dr. Meaghan Thumath. They are both clinical assistant professors with the UBC School of Nursing, as well as holding cross appointments with BC Cancer and Vancouver Coastal in health. But anyways, Dr. Naz Havaei is an assistant professor in the school with a focus on nursing workforce and health systems research. And Dr. Havaei teaches graduate courses in nursing leadership. Dr. Leigh Chapman is Canada's Chief Nursing Officer and has agreed to play the role of the respondent on the panel, so as not to scoop her keynote talk later this evening. As each of our panelists' bios are available online, you can follow the QR code on the screen. I'm going to maximize our time together to launch into our dialogue questions. I'd like to start by way of a more fulsome introduction by asking each of our panelists to tell us a little bit about their leadership journey. Dr. Lambert.
Oh, it's
would you like
automatic.
to start?
Thank you. So I want to talk about my journey because it's a little unconventional. Nursing is actually a second career in my career trajectory, and I started in finance and worked there for 10 years. And full disclosure, had a quarter life crisis and wanted to do something more with my life that felt more meaningful. And so I did career testing and everything came back medical related. I ended up choosing nursing. And so fast forward, after graduating with my undergrad degree, my younger brother was diagnosed with metastatic cancer, which really fueled my fire to want to do something at the system level. And so I started my master's here at UBC. And shortly into that was encouraged and by Sabrina as well to fast track to the PhD program, which I did. Ended up taking a lot longer than I had expected. I had 3 kids during the PhD, so 3 different stop-start time periods, which, you know, actually turned out way better than I had expected. And then upon graduation from my PhD, I was awarded a CHR Michael Smith Health System Impact postdoc fellowship, where I was embedded at BC Cancer, working on a program of work related to transitions in care for breast cancer patients. And at the time, the organization was developing the Nursing and Allied Health Research and Knowledge Translation Department. And I was consulting with them on what that, you know, ideally could look like. And meanwhile, I was actually trying to recruit a rock star from somewhere else in Canada to come and lead this work, and became, you know, had a closer working relationship with leadership at the time, who asked me to apply for the role. And I did. And now I'm still holding that role after 3.5 years. But it was just an incredible opportunity to leverage my background prior to nursing in finance and understanding health system drivers, but also utilizing my, you know, professional experience as a nurse as well as my academic training to move health system transformation forward. And so I get the incredible opportunity today to work with an amazing team. I get to sit up here because I'm standing on the shoulders of giants such as, you know, Fisha Howard and Sally Thorne and others who really rallied around me in support of onboarding this new role and the possibilities that they had advocated for many years. And shortly before, a few years before, many of you know Dr. Tracy Truant, who held an inaugural role at BC Cancer as the Director of Research and Innovation. And sadly, you know, she was a close mentor to many of us, and then passed away from cancer as well. And so there's a group of us that are really determined to bring the work that she had envisioned to fruition, and have magically somehow been able to do a lot of the things that we set out to do. And so I get to work with amazing humans that are actually here today, Jagbeer and Carissa and Scott and Bonnie. But I think it really demonstrates when you harness the power of nurses who, you know, not only have diverse professional backgrounds, but also have graduate training in what's possible in the health system.
Wow, that's amazing. So Dr. Thumath, as a clinical assistant professor in the School of Nursing, what has been your journey in leadership?
Thanks so much. Yeah, I mean, it's been a wonderful ride, and a lot of it thanks to many of the folks here in the room. So I see some of my mentors and faculty that encouraged me when I did my undergrad at UBC School of Nursing and some of my graduate training as well. And I think for me, the sort of red thread through my journey has really been health equity in marginalized populations. So I started before I was a nurse as a harm reduction worker, and I worked in needle and syringe programs. And I think I worked in various youth HIV programs. And so when I did my kind of interview for the street nurse program, which was one of my first jobs at BCCDC out of my undergrad, I remember kind of telling the story like, all right, what led you to apply? And I was like, oh, well, I think it might have been when I got suspended for giving out condoms in the locker. Like I was always getting in trouble, but I had been, involved in harm reduction really early. And that's kind of what inspired me to go into nursing. So I always knew that would be a big part of my work. And I think for me, my journey is really, then the sweet spot for me is having a mix of sort of what I would say like 3 core areas. So clinical, research, and policy work. And one of my most impactful work experience clinically was at Havaei, which is a pregnancy and addictions outreach program, and worked with some folks in the audience in various outreach nursing jobs. And that really lit the fire under me to sort of use my nursing clinical journey to advance really system change for the women that we were serving primarily in the downtown east side at that time. And I just saw really the major gaps, like social justice gaps for particularly Indigenous women when they were up against the child welfare system, the sort of systemic discrimination they faced. And so that actually led me to, I had done a master's already, but it led me to sort of do my PhD, which I started here at UBC Nursing, and eventually managed to do sort of a co-thing with the University of Oxford. And there I did my thesis on the impact of the child welfare system on maternal health. And so really trying to advance and use epidemiology to demonstrate what we knew clinically, which was that when you take women's children away, the grief process is so intense that it's deadly. And that was sort of what we found. Women whose children were apprehended were sort of 10 times more likely to die than women who had not had their children apprehended after controlling for other confounders. And that what was really rewarding about doing a PhD in a clinical area was the ability to then transition that into actual policy work. And I also, like you, did the PhD long road. I think I ran into one of the physicians I work with who's like, you've been doing your PhD ever since I've known you. I finally finished. And, it probably was at least 10 years. I also have 2 kids. And one of my side journey when I paused was to become the chief of staff to the Minister of Mental Health and Addictions. And that was where I really got to see, like, how can we use the power of nursing and nursing voice to advance health policy, and how can we really bring our values and all of our amazing sort of nursing training and make change for the people we serve. And so had various sort of leadership roles in government. We are in an interregnum, what we call period, or a caretaker mode in government. So we're a few weeks away from an election in British Columbia, so we won't necessarily talk too much about current state roles, but all of the roles that I've had have been really about advancing health equity for primarily marginalized populations, and that's been a huge honor. And my final kind of comment is the ability to sort of think globally and sort of act locally. And I've had the huge privilege to also work in some of my areas with the World Health Organization and the Global Fund to End AIDS, TB, and Malaria, and UNICEF, and various other UN agencies. And that's primarily been at that intersection of HIV outbreaks, public health emergencies, and sort of, it's all like injustice is everywhere. It doesn't matter if it's cancer care, if it's your health human resources workforce, if you're the chief nursing officer. Like, I think we're all doing different bits to work to reduce unfair and unjust differences in health for our clients. And that thread is very rewarding. And so if you're not already interested in health equity, I would invite you to join us. Otherwise, I look forward to the conversation.
Great. Dr. Havaei?
Sure. It's tough to go after Leah and Meaghan. I'm not as esteemed as some of my colleagues here. I don't have a leadership role, but I perhaps could tell you a little bit about how I got interested in this area of nursing leadership. And I would say for me, probably my interest in this area started in our own undergraduate nursing program, where I was first introduced to many leadership concepts and theories in our Nursing 351 leadership policy and informatics course. And back then, years ago, it was my mentor, former mentor, Dr. Maura McPhee, who was teaching that course. And after graduation and starting to work as a bedside nurse, I actually saw the applicability of many of those leadership concepts and theories. And most importantly, it was essentially the style or the strategies that the nursing leader was essentially using in their practice. And essentially, I sort of saw the difference that that would make in relation to my experiences and also the experiences of my colleagues. On one side of the spectrum, you'd have these really amazing nurse leaders, nurse managers, who would go over and above to build positive relationships with their staff and to ensure the health and safety of the staff and their patients. And on the opposite side of the spectrum, quite unfortunately, there were these nursing leaders who did not really care about the health and safety of their staff, or there were, I would say, like overall very either hierarchical or top down in their leadership style, or they were absent, they were not there. And so when I speak to my colleagues, we talk about how unhappy we were with our jobs, and we would start to show signs of burnout, detaching from the workplace, detaching from our patients, starting to look for jobs. And I'd say probably the new grads were the ones that were most severely impacted. Some of them started, questioning whether or not nursing was the right profession for them. So after that experience, when I came back to do my graduate studies, I actually found out that there was quite a bit of, research evidence backing up my firsthand experience. The work of some amazing nurse researchers like Greta Cumming, the systematic review that she had done looking at, over 130 research papers on nursing leadership styles, and essentially concluding that relational styles of leading, they would result in most positive outcomes for patients, for nurses, for the healthcare organization. And there were also other, nurse researchers, really prominent nurse researchers that that I found really inspiring, studying healthy workplaces, healthy work environments, and the impact or the role that nurse leaders would play in fostering and creating those healthy work environments. And that literature really got me interested. And from there on, I decided to pursue a PhD, and I started working with my supervisor, Dr. Maura McPhee. After that, did my postdoc with Dr. Elizabeth Savick. And from there on, established a program of research around health systems, health services research, studying all of those workplace and organizational factors that essentially enable nurses, enable them, foster their ability to deliver high quality, safe patient care. That's my journey.
Wow, that's great. Dr. Chapman, did you want to provide any early responses about themes that you're hearing?
Sure. I mean, I definitely feel very inadequate beside my esteemed colleagues. A couple things I will say is many of us are PhD long haulers. And I think when you're done, nobody really says, how long did it take you, right? You got the degree. I also think there's a trend towards nursing as a second degree and the richness that comes. But regardless, I think that it's something for us to sort of pause and reflect on, because we spend an inordinate amount of time telling students and new graduates what they don't know without actually recognizing the lens that they bring, whether they have previous education or not. And I think that's nursing was a second degree for me as well. And I took the full 4 years, even though I could have done an accelerated route, because I wanted to enjoy life and travel and work and pay for my schooling. And I think maybe the other piece I would reflect on is that it's not always a straight journey. And so like my career has really been very circuitous, I would say, and really kind of about embracing opportunities. I think, I've done some things and I've thought, never want to do that again. And I've done other things and I've thought that's really cool. Let me lean into that and do more of that. And I think that's the benefit of nursing. I have certainly gone in and out of clinical practice over my 21 years as a nurse. Never thought I would be in this role that I'm in, but life is strange and interesting. And I think we just have to stay open to the opportunities that both life and the profession afford us.
That's great. We are going to put up a Slido, and you can think about questions to ask our esteemed panel. But I'll start with some questions first. So, Leah, in the area of equity in cancer care, what do you see as some of the greatest areas of possibility to advance nursing leadership?
That's a great question. I say that not only in relation to health and healthcare equity, but just more broadly, nurses are very uniquely positioned to drive meaningful change, and more specifically in relation to addressing longstanding gaps in health and healthcare equity, in particular in the cancer care sector, which is the research that I do, and a lot of that is because as the largest sector of the health workforce, nurses are often the ones who actually spend the most time with patients, and so they have this unparalleled insight into not only patient needs, but healthcare processes and system challenges. And so that means that they're often the first people to see inequities and also to come up with opportunities for improvement. But part of the challenge in driving system change, which is often what's needed in relation to healthcare equity, is structural changes, is that nurses need to have a seat at the table, and we aren't always afforded that privilege. And so, as colleagues say, you have to kind of elbow your way in there. Nurses need to be a part of decision-making in healthcare. They need to be a part of executive meetings. They need to be a part of policy discussions and strategic planning sessions, and talking about how, we ought to be changing the structure and delivery of healthcare within our healthcare system, not only in BC, but also across Canada. But in order to do that, we need to also create pathways for our nurses to take on those leadership roles, because there's really there's an immense potential for nurses to step into that space and be leaders in healthcare transformation. And I'd say, given the capacity challenges across our healthcare system in general, and due to a growing and aging population, people living longer with chronic illnesses, there is tremendous strain. And so I'd say more than ever, we really need to fully leverage the expertise that nursing brings to that table. But I think it's onus upon those of us in leadership positions to create that space and to advocate and to make sure that we pull up a seat at the table and that we are a part of informing health system transformation. And I think that using research methodology and knowledge mobilization methodologies are an excellent way of doing that, as those of us who are positioned in dual roles across the health system and academic environment. And that's some of the work that, we've been very successful in informing policy at the provincial level and hopefully the national level soon. But my colleagues, Dr. Natasha Pradambala and Sandra Luck here today, we've done a lot of really cool work, I think, and that is just an incredible untapped opportunity that nurses have to do that kind of work.
That's great. Meaghan, I have a question for you. You've held several public positions and public health leadership roles as well. How have you enacted the power of nursing to drive change for people and communities that you serve?
Great. I mean, I love just sort of riffing off Leah too. Like, I heard this great quote at an event I was at the other day, like, if you're not at the table, you're on the menu. I love that. I hadn't heard it before, but I thought it was brilliant. Like, and nurses often we're just, we're not there. And we are so so trusted by the public. We have so much to build off of. And I think we have such a unique position where we really can see the whole client journey and we think across silos. And that's like such a gift. Like if you're earlier in your leadership journey, would just encourage, like, speak up. You see things that other people don't see. And I mean, I'm an outreach nurse, and there's a few outreach nurses in the room, and it's like you see it even more. Like when you're trying to get your clients in for something, and they are people who use drugs that are stigmatized, or people with mental health challenges, and you're trying to get them access to like basic dignified care, and you just see immediately the gaps and the holes in the system. And all of us who've supported family members, I'm sure, have seen that as well. And so you have a vision, and what I've learned is to be able to use that sort of double-edged sort of like storytelling and data. And so I think that's again where the graduate training comes in. We can use, and the leaders that you'll be speaking to have such different brains. So I just love like figuring out what makes this person tick, that I'm this policymaker, this minister, this deputy minister that I'm trying to convince about a policy change. What do I know about them? What do I know? How can we find a win-win? And then what are their key objectives, and how can I sort of ride the coattails of a policy opportunity and convince them to sort of make the system more equitable? I mean, a brief story I'd talk about is some wins we had during the COVID pandemic. There was some things we'd been trying to push through for many years around access to safer supply. And we were able to sort of frame it in the communicable disease lens and almost hack people's fear of COVID and push forward some innovation in that space that we thought was going to be more useful for community and really reduce overdose, and we hope to save lives. And so just learning the power of seizing the moment, never waste a crisis is another favorite. And I think nurses are awesome in times of crisis. And so that's something I've certainly used a lot in my journey. And then really, if you haven't done a lot of communications training, that's just another hot tip that I would pass on. I think often the school gives us those opportunities. UBC Media is amazing. We were all calling our comms people. Get to know your comms person. They're your best friend, and use your voice to tell stories.
Those are great. Those are great. So a seat at the table, speaking up. You guys see a lot. So you see a lot of the gaps. So that's really important, to use your voice, to have it heard, to use storytelling, and to use data, as well as comms training. So as in addition to your health systems research, you also teach graduate nursing leadership courses. What are some core areas that educators can contribute to equipping nurses for leadership across multiple domains, specifically storytelling and data?
Thank you for that question. I actually like to start from a different place, because in order to answer that question, I think we need to have a common understanding of what are those most pressing issues that our healthcare system is experiencing right now. And in my evidence-informed perspective, I think our nursing workforce crisis is probably one of those very pressing issues that our healthcare system is facing right now. There was a forecasting study back in 2018 that came out and said that we are going to have a shortage of nearly 130,000 nurses by 2030. So that's probably around 6 years from now. Given that, I actually think that we need to be educating our emerging nurse leaders on system-level strategies that foster nurse retention, nurse recruitment, and decrease nurse turnover. And by systems level strategies, I mean those strategies that are, just past the bedside and the unit level and are, organizational or perhaps even provincial or national. Back in March of 2024, Leigh actually developed and published this nursing toolkit that actually has a series of very concrete, actionable recommendations, things like safe staffing, professional development opportunities and mentorship, work-life balance, flexible scheduling, offering nurses mental health support and wellness programs, a bunch of them. And I think in our graduate nursing leadership courses, we actually do a really good job, Sabrina, covering a lot of these areas. But perhaps one of the areas that we could be doing a better job on, in line with what Leah and Meaghan discussed, is essentially educating emerging nurse leaders on strategies and ways of fostering their sense of power, their ability to speak up, their political savviness, and all of that with an eye to, give them a sense of empowerment so that they can actually engage with and participate in some of those, policy conversations and policy decisions organizationally, provincially, and nationally. And I think our emerging nurse leaders are actually quite fortunate for having, amazing leaders like Leah and Leigh and Meaghan, that have essentially paved the way for them. So they have these great role models in front of them that is going to make things a lot easier for them, essentially.
That's great. So system level strategies, learning strategy, how do you do strategy? And I think I will just add that you actually need to be able to speak to the problem. So the ability to reframe and using the language that policymakers understand. And so telling a story is really important, but so are the numbers. So is the data. So using data and learning that in grad school and how you use the data is really important. But Leigh, we are looking forward so much to your keynote lecture, but we would really appreciate your thoughts and response to some of the themes that you now see emerging.
Okay, well, I think in addition to needing to speak to the data and the stories, we need to, data and evidence, I would say, because we're at a time when decisions are being made often on ideology and not on evidence. And there's a real anti-science movement. And I think nurses have always had an important role to play when it comes to brokering knowledge and speaking from an evidence-based perspective. And I think that is never, it's ever more important in this context. I will agree that we absolutely need a seat at the table, and once we have it, we can't assume we'll always have it. And so that is where we also need to be very mindful that it's about the seat, not about the individual who's occupying the seat or the role. And we absolutely need the nursing lens in terms of structural change that's needed in healthcare, because we're so proximal to the point of care, because we have that broad, systems level perspective. We're often the MacGyvers of healthcare, cobbling together the system, the disparate parts of the system that are really not intended to function in the way that they need to in the service of those we serve, and in providing patient care. And often I think that's the key, is that nurses have such an important role when it comes to decision-making authority and that broad systems level perspective. But it's often said that, we should pay attention to nurses because we're the most numerous, we're the largest in number in terms of regulated health workforce. And I actually think it's the opposite. It's not because we're so numerous, it's because the role we play is so important. So really thinking about that, and perhaps maybe just to end, that I think that I do really think I sit in the space at the sort of pan-Canadian level often, but I think I'm often dipping down to the individual level, to the organizational level, to the provincial or territorial level, and we need to kind of work from a multi-level perspective in really thinking about things across the continuum, even from a global context. I know Meaghan's done a lot of really great international work as well, and then I would just remind us that we have to, and thank you, Naz, for the plug on the retention toolkit. Naz and I just met today, so that was not, it wasn't planned, but I very much appreciate the shout out to the nursing retention toolkit as a pan-Canadian strategy. And I will say, there is interest in the toolkit across the world. Nursing doesn't own retention issues. There are certainly across many different professions, but I think we tapped into something in Canada in the co-development of that nursing retention toolkit. There's interest. I've presented to the Euro region of the World Health Organization, which includes all the STAN countries, so Kazakhstan, Uzbekistan, all the Russian-speaking countries. It's broader than the EU. There's interest from Australia. There's interest from many countries in Africa as well as our Pan-American colleagues in the Pan-American Health Organization. So, and just a reminder of the International Council of Nurses, which states that nurses actually have the power to change entire societies. And there's nothing more powerful than that, right? That really is about the economic power of nursing care and thinking about the role that we do and the legacy that we can impart on the future generations, on current and future generations of people in Canada. And I think there's tremendous power in that we absolutely need to tap into.
That's great. Thank you. Thank you for those words. Okay, so I'm going to ask some questions. So the first question I'm going to ask is, this person had to let go of their clinical practice in their educational leadership role. What are your thoughts on nurse leaders who are not actively in clinical practice? Anyone on the panel want to take that one?
I could say something about it. It's a lot of the work that I've done in partnership with Natasha and Sandra more recently is around advanced practice nursing. And so the clinical component as a non-contract role has been a hot topic. And it's also, been a topic across the health system, in recognizing that in other disciplines, scientists, leaders, et cetera, are supported and the system is structured in such a way that they can maintain a clinical practice, which isn't always the case for nursing. But I do think it's possible. And I think that there are discussions around what that could ideally look like, so that it would enable, folks like myself to stay more close to direct, point of care, and have that on the ground reality of what it's like in and day out. And I think, speaking to what I mentioned earlier around nurses being ideally positioned for leadership, also creating that pipeline of communication and information flow throughout all levels of nursing in an organization. So I think there's ways to do it. I don't know that we have it fully figured out yet, but I do know that it's being discussed.
That's great. Meaghan?
Yeah, I mean, I get this question a lot. I've managed to keep my clinical day, and it's always a fight. I think it's about negotiating it before you start as much as you can. And I mean, I'm somewhat lucky because I do have an advanced practice certification, so in STIs and if you know the BC context, STIs and contraception. So it does allow sort of a more of an episodic element, but the more complicated healthcare gets, particularly with our electronic medical record systems, like I had to let go and change organizations because I just couldn't find the week that needed to do the Cerner transition, when that happened at one of the hospitals I was working at. So I've found it's been easier to work with sort of some of the smaller nonprofits that have different EMR systems. So that's where I'm currently doing my clinical time. And again, I think it's just carving it out and being really firm that it's a must-have. And we are in demand. Like there is a nursing shortage. So I would encourage folks, if at your next transition, to try and make it something. And there's been some really great gains made. I know some of the organizations I've worked for have sort of really worked collaboratively with the union and others to clarify, like, we can now work casually. That's now in the contract as excluded leaders. And so that's a huge win, and something that if you've let your clinical day go, now is a good time to bring it back.
Thank you. Okay, I'm going to move on to another question, and the question is around minority groups. So we're going to start with the minority group question first. So how do you demonstrate equity for minority groups at your table? And do you strategically hold the door open for them? And how do you do that? I think we'd love to learn about that.
Can I take?
Yes, Leigh,
I'll
please.
take a stab at that one to start. But that's something I've been very mindful of in my current role and position, and really have benefited from working with and being, very intentional about the way that I do the work. So, working closely with the Canadian Indigenous Nurses Association, the Canadian Black Nurses Alliance, Pan-Canadian Association of African Nurses of African Descent. And I will say, just as an example, and other equity deserving groups, those are just a few that come to mind. But I think that it's upon us as nurse leaders to really kind of acknowledge the structures that create barriers for inclusion, meaningful inclusion, and from an equity and diversity and reconciliation lens. And I will say, at the Nursing Retention Forum last June, in the co-development of the Nursing Retention Toolkit with nurses from across the country, we were very intentional about centering those exact voices. So in the ministerial roundtable with the ministers engaging with nurses, we made a point of putting Indigenous nurses, Black nurses on the panel to really focus on that important perspective. And I think that's something I can do as a white Chief Nursing Officer of Canada, and really try to pave the way for more meaningful inclusion in subsequent folks who are occupying this role.
Yes.
Can I add? I totally agree with everything Leigh said, but perhaps a bit more concrete strategies for those nurse leaders and managers in practice would be actually to have conversation with those minority groups to learn from them. What does enhance their participation? What does participation mean to them? Not everybody's going to feel comfortable speaking up at a large staff meeting. Does that mean you'll have to offer other modes of, collecting feedback and obtaining input from staff, and sort of thinking about all of those, factors that might enhance a staff person who belongs to one of those underrepresented groups? What would actually enhance their participation? I think would be really important to talk to them and see what it is that they want, and then actually integrate that into your practice when you talk to them and invite them to meetings.
That's great. Thank you. Thank you for those concrete strategies. Okay, I'm going to ask another question here, and this is from Kyra. Historically, the Canadian nurse is a white cis woman. How does your embodied reality limit your understanding on who is encouraged to be a nurse leader today? Leah or Meaghan, why don't we start with you, since you didn't answer the first question?
Happy to chime in. Yeah, I mean, I think like white supremacy and sort of colonial violence is such a lived reality for all of us in British Columbia. And I'm a child of immigrants and as a white settler living on unceded ancestral, Squamish, Musqueam, and Tsleil-Waututh territories. And so have lived my whole life with that sort of unearned privilege that have came here as the children of settlers. And it's something that in my own leadership try to really center opportunities, have concrete sort of hiring practices. We have pathways for Indigenous nurses in our organization. We certainly have been centering voices of sort of equity deserving groups in many of the strategies I've been forward. Leigh mentioned we've been working with the Black Nurses Association, have been working some of the strategies I'm building now on privileging the voices of those who've been left behind. And so very mindful when I talk a lot about like leaving the ladder up. And so would really welcome sort of input and feedback and making space from people that the more we can do that. And I mean, even this panel, in some ways we've got some, but there's more of us who are at least white passing than not. So I think it's a really important question and something we can all do better with. So thanks.
I think I'll just add to that, you know, I don't pretend to understand fully, and I know that that's not going to be reality. And one of the philosophies that we have on our team is our goal is to be the imperfect friend. And so I see it as an added layer of responsibility as, you know, a Caucasian, you know, woman in a leadership position, and really realizing the, you know, unearned privileges that I have benefited from, to use that for creating structural change. And we have been able to make good strides. And I think it's about also picking your battles. And there's just some battles and hills that, you know, we have been willing to die on to make that structural change, because if those opportunities aren't present, then we're never going to see that come to fruition. And so, you know, in PHSA, we have one of two only clinical nurse specialist roles focused on Indigenous cultural safety and wellness. And it's something that we really strongly advocated for, and we're able to see through fruition. So I think it's examples like that, being the imperfect friend. And I think more than anything, literally just walking the talk, actually putting things into action, rather than just speaking about it.
Yeah, thank you for that. So the imperfect friend, and I would say actually an ally, right? So we talk a little bit about allyship in some of the work that we do. And I just also want to recognize that it's about leadership of not necessarily, quote, underrepresented for the population, Black and Indigenous, but I also want to recognize that there are many other groups that also don't actually make it into leadership. So I just want to talk about something that I learned recently from Dr. Lydia Wittenbrook's project and one of her students, where Chinese women were not allowed to be nurses until 1949 in British Columbia. And there's also a need for South Asian leadership. So to ignore the fact that, you know, there are other groups that actually haven't made it into leadership positions, or they somehow don't fit with whatever, is also, I think, something that we need to be thinking about quite seriously. So I'm going to move on to the next question. I think we have time for maybe one or two questions more. And I'm going to move to this one about Indigenous nursing leadership because it's related. So how do we advance Indigenous nursing leadership in the system? This person says, I still don't see representation, and it has been a long time since TRC calls to action. So this is specific to Indigenous. Naz, do you want to?
Sure. I can talk a little bit about some of the things that we've done in our nursing leadership, graduate level nursing leadership course, to try to essentially educate our emerging leaders on Indigenous leadership, strategies. And one of the things that actually last week I got our students to do was to watch this video that one of our Indigenous experts, one of our PhD students, Olivia Marco, had done on Indigenous leadership and strategies that Indigenous leaders use in practice. And as a follow-up reflective question, I actually got students, Sabrina, to reflect on, what are some of those Indigenous leadership strategies that could be beneficial to Western healthcare leaders, just as a way to essentially foster their inclusive leadership strategies. So these are some of the things that we've been doing in our program. This was just an example. I mean, there's quite a bit of room, I think, still for improvement in terms of, doing a better job with recruiting and hiring Indigenous nurse leaders in practice. But we'd have to start from a place, and in our program, that's where we've started.
Thank you, Naz.
I'll just make a very quick comment because it's hard to answer succinctly, but just to say we have a tremendous amount of work to do. One of the things that is on deck for me is a companion guide to the Nursing Retention Toolkit. And I struggle with the idea of companion guide, but I think that is the working title for now. And I think we need to embrace that the companions can walk hand in hand. And the goal of the companion guide to the the Indigenous companion guide to the nursing retention toolkit is to focus on the Indigenous nursing workforce, to also include recruitment, because we know that retention is not enough when there are structural barriers to even entering the profession. So that's something that we hope to deliver in the next year.
That's great. Okay, one more question. So how do you see nurses advancing their leadership careers, but leaving gaps and loss of experience when they move up? And I don't know if the person wants to clarify the question or, oh, Leah, do you want to
I was going
answer?
to say, can you repeat it again?
Yeah, how do you see nurses advancing their leadership career, but leaving gaps and loss of experience when they move up?
I'm not sure what they mean by loss.
I think well, does the person want to speak, or I can try to interpret? I think what they're meaning is that they're going up into a leadership position, and so then there's a gap where they were. Is that maybe correct?
Probably gaps in hands-on nursing experience might be. That's what I said.
Yeah. Yeah, so there's a vacant spot that's left because the person has moved up into a leadership position, and so then there's a vacant spot. So I guess the flip side might be, yes, please.
So maybe I'll just sort of riff on some ideas that come to mind. I know when I came into this role, it had been vacant for over a decade, for 11 years. And there was a real desire to have someone connected to practice. And so it was essentially, the role was reinstated as a part-time position because they didn't want a bureaucrat. Although I am full-time, I will assure you, I'm still not a bureaucrat. 2 years in, I'm a pretend bureaucrat or nurse in a bureaucratic role. But I think that we can wear many hats in different roles. And I think we also have to think about when instead of thinking it as a gap that we're leaving behind, perhaps thinking of it as working as a nurse from a very different standpoint, different vantage point, but always from that nursing lens. There's, whether I'm, reviewing remarks for a minister or a prime minister, or, working with the provinces and territories, is always from that nursing lens. And I think we can leverage that nursing knowledge for different things. I don't think it's necessarily a gap. I think it's just a different opportunity. And leadership is also about role modeling from different standpoints as well.
Yeah, that's great. Thank you. So I am going to invite all of you that are here to enjoy talking to the panelists over dinner, because we're going to take a break for dinner. And those people who are online, please use the same Zoom link for the 7 p.m. keynote lecture, or you could just stay on the line and go help yourself to dinner in your own house or wherever you're at. And for the light dinner this evening, we have kept the format simple. So there are chicken wraps or gluten-free vegan bowls. And we have an event photographer also who will be around capturing the moment. So we'll see you back here at 7. And I just want to give a big shout out to Leigh for all of the work that she has done in putting this together. So thank you to our panelists, and thank you to Leigh.